Good afternoon, everybody. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the State of the Science Update and what to expect. This is part 2 of a 2-part series. And my name is Michelle Whitcup. I'm the head of research at the National Hemophilia Foundation. I'm just letting people into the room right now. So we'll give it a few minutes and let the room populate, and then we'll go ahead and get started. Hi, excuse me, my voice is cracking today. Hi, everybody. We're going to let the room just populate for another minute or so, and then we will go ahead and get started. So good afternoon, everybody. We're going to go ahead and get started, and we'll have more people join us as we move along. I'd like to thank you all again for joining us for our weekly Wednesday webinar series. Today's webinar is on the State of the Science Update and what to expect. This is part 2 of a 2-part series. My name is Michelle Whitcup, and I'm the head of research here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, August 13th. I'm joined today by our State of the Science Working Group chairs, who I will ask to introduce themselves as they begin their update. But today we have Working Group 1, Hemophilia A and B, Working Group 2, von Willebrand's, platelet disorders, and other mucocutaneous inherited bleeding disorders. Working Group 5, which is diversity, equity, and inclusion, health services research, and implementation science. And then Working Group 6, the workforce. So with that, I'd like to thank you all for taking the time to join us, and I will turn it over to Dr. Aneta Vandragalski. Dr. Vandragalski?
Hello, everyone. So my task is today to bring closer to you a preview regarding the research priorities for hemophilia A and B. So welcome. To introduce myself, I'm a professor of clinical medicine, and I'm directing the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. And I'm co-chairing this effort with Bobby, Dr. Tran, who is an assistant professor at the Center for Bleeding and Clotting Disorders in Emory. So why did we get involved with the State of the Science Summit? Well, first, opportunity for meaningful contributions to an innovative research blueprint with multiple categories and research topics within this one big group of hemophilia A and B. The lifespan of hemophilia with aging patients becoming increasingly relevant. Then this whole approach appeared very patient relevant and patient centered, not just benchwork. It is associated with our own research interests. And then the collaboration with truly a broad array of stakeholders bringing unique aspects to light. So the community approach involving not only medical providers, but also basic researchers, patients, caregivers, chapter representatives, and industry partners was all very appealing. And then finally, there was also crosstalk with other disciplines. For instance, pain management with a pain expert once it came to arthropathy. What did we hope to achieve? Clearly, a better understanding of patient values and priorities in research. We hoped also to achieve these meaningful interactions and opportunities for brainstorming and thought development with colleagues and community representatives. And that's extremely important because often we just sit in our own shells, have sort of a boxed view of what research should look like or of our own interest without too much crosstalk. So this was truly a unique opportunity, and we hoped to achieve to deepen these collaborations. Also, we wanted to identify gaps in infrastructure that are in the way of meaningful research projects. And then finally, forging collaborations through shared priority formulation and decision-making. So it's always good to have a process in place. And I have to say, this was a 6-month process where we met fairly regularly, almost on a weekly basis, to flesh out these priorities. So quite involved and quite a lot of crosstalk. So with that, the hope was to achieve a cohesive research blueprint divided into subcategories with prioritization of research questions based on urgency, feasibility, and available infrastructure. So now, why should the inheritable blood disorder community be excited about the products of these working groups, and especially our working group? Well, it is the creation of new knowledge involving truly everyone by being tasked to think out of the box. It was a multidisciplinary approach with experts from different fields providing valuable input. And the thought process was very open and not stifled by a priori assumptions like, oh, this cannot be done because. We were just really thinking without limitations. So just to pull us back a little bit, there are many open questions for especially aging persons with hemophilia. Clearly, lifelong bleed control is at the center of it all and won't change. But after the transition from childhood to adulthood, many new fields are developing. This is the management of the arthropathy that will accompany many patients for the next 60 years of their lives once they exit childhood. Cardiovascular care with a focus on hypertension, bone health, health literacy, and socioeconomics. So actually quite a big task. And so this was the initial scheme given to us by National Hemophilia Foundation in terms of multidisciplinary basic translational research divided into therapeutics, diagnostics, and mechanisms of disease. And you can read a little bit for yourself, but therapeutics, for instance, gene therapy comes to mind, novel agents, factorless, and so on. And then on the other hand, we had multidisciplinary clinical studies and trials. What is really important with all these new agents coming to market? For instance, post-licensure therapeutic regimen implementation, data collection, what are comorbidities that need to be assessed, aging in hemophilia, and so on and so forth. So I just leave the slide for you for a few seconds, then you can read for yourself. So with that in mind, with that basic scheme, we formed 7 working subgroups. And you can see here, we picked the lead for each of those subgroups: arthropathy, pain, bone health. It was Bruno Steiner from the Washington Center of Bleeding Disorders. For inhibitors, it was Dr. Meeks. For diagnostics, it was myself. For gene therapy, it was Dr. Rice from St. Jude. For transition, it was Dr. Thornburg, my colleague here at Children's Hospital, Rady Children's Hospital in San Diego. For disparities in literacy, it was Dr. Tran, my co-chair. And then cardiovascular disease was led by Dr. Doris Kwan from Los Angeles. And then each of these subgroups had a number of members that belonged to our larger panel. And then we almost met on a weekly basis to flesh out important questions. And I think that's all I want to give you, not to give away too much. We truly look forward to the state of the Science Summit, where we present you with more details regarding the process, obviously with the results of each working group, and hoping for a lively discussion, but you are welcome to even ask now. Thank you. That would be it for me.
All right, well, thank you, Dr. Van Dragalski. And then it looks like Dr. Sidonio had some internet problems, so we will move to Dr. Baker, if that is okay with you. Dr. Baker?
Yes, that is. That's
Wonderful.
terrific.
Thank you for being so flexible.
Wonderful. And let me bring up my slides and say thank you and welcome everybody to the presentation. We really look forward to this opportunity to give you just a taste of our Working Group 5, which focused on diversity, equity, and inclusion, health services research, and implementation science. Our three co-chairs, myself, I am the Director of Public Health at the Center for Inherited Blood Disorders in Orange County, and I also serve as the Regional Administrator for the Western States Hemophilia Treatment Center Network, also known as Region 9. I had two wonderful co-chairs, and they're with me today behind the scenes. Dr. Tyler Buckner from the Hemophilia and Thrombosis Center of Denver, and also Dr. Vanessa Byams from the Centers for Disease Control and Prevention.
Excuse me, Dr. Baker, we are not able to see your slides.
Oh my goodness. Well, let me see what I can do to change that. All right, let's see what we can do. So I will need to have my screen shared, correct? Let us do that. How's that? Are we up yet?
It's starting.
Okay.
We can see your email.
Oh, that's really embarrassing. So we don't want to see that. Let me click off of that. Don't we all just love Zoom at this time, right?
I know.
All right. Well, let's see what we can do. I'll say hello to everybody in person here, and let's try to get this up again. Nope, that is not working. My recommendation at this point is why don't we go to another colleague, and I think that would work out better. Would that be acceptable?
Yeah, that would be fine. Dr. Sidonio, you were able to get back on. Will you
Great.
be able to join and do your slides real quick?
Yes, you'll just have to make me co-host so I can share. Probably because I had to re-log in. Sorry about that. There's some storms coming through here. All right. Okay, let me get this up here and move all the things. Can you see the correct presentation, not the presenter mode?
Yes.
It's in, okay, all right. Yeah, so thanks everybody. You know, obviously we have a limited amount of time, but I wanted to talk about what we did in Working Group 2. We had a lot of disorders to talk about. So let's go ahead and get started. And as you can see here, you know, obviously I could not have done this without a wonderful co-chair in Dr. Veronica Flood. Also a master of spreadsheets as well, so she can add that to her CV. But we were represented, both of us represented a very large group of active participants, and they're listed here. We had people from industry, we had consumers / patients, physical therapists, social workers, we had basic scientists. We had a lot of different people that were helping out on this. And obviously, I truly appreciate all of their input. And I think we're proud of what we ended up with. So this is the schema of what we were tasked to do. And as you can see here, not only were we covering von Willebrand disease, we're also covering inherited platelet disorders, and other mucocutaneous bleeding disorders. We were also tasked to cover novel therapeutics, diagnostics, mechanisms of disease, specifically on the biology of mucocutaneous bleeding. So we learned a lot in the few months in which we did this. And obviously looking at lifespan, data collection, outcomes, aging, all of the things that I think we're all going to be looking at multiple disorders. And so we had a number of disorders, not only von Willebrand's, we had inherited platelet disorders, we had Ehlers-Danlos syndrome, we had HHT, so we had some providers that really provided some assistance on this. We covered bleeding of unknown cause, in which there'll be some papers out on this in the next few weeks. Additionally, we covered the topics of aging, novel therapeutics, and the biology of mucocutaneous bleeding. As mentioned before, just as a reminder, when you look at the scores, you could have quite a large score, but you can see here that the max score was quite high, and very few of them were able to achieve that. And you can see here, risk only took away points from the total score. So there are a number of major themes that came out of our discussion. One of them was really, we need to do a better, to gain a better understanding of the basic biology of how cells and proteins interact in the microenvironment, and how this interaction affects von Willebrand's, Ehlers-Danlos, and HHT, as well as inherited platelet disorders. We learned a lot about, we wanted to talk a lot about mucocutaneous bleeding disorders, what happens over time. And then really, we wanted to focus on better diagnostic testing and better definitions. And obviously trying to be creative with the armamentarium of therapeutics that we have currently. I'm not going to go through all of these. There's actually 2 slides. And we really felt like there was such a limited understanding of the biology of mucocutaneous bleeding that we felt that it warranted lots and lots of research priorities. I'm not going to go through all of these, but you can see the first few of them focused on inherent defects in wound healing, the differences in the biology of the different parts of the mucocutaneous location. So obviously there's differences in the GI tract, nasal tissue, uterus, uterine wall. And obviously we wanted to look at the functions of von Willebrand's and regulating vascular integrity, the role of hormones in this microenvironment. So a number of things were covered and were given pretty high priority. Additionally, you can see here, we need to do a better job of developing animal and in vitro models to really be able to study this. And our basic scientists really would appreciate this as well. So a lot of topics covered, a lot to be done in the field of biology of mucocutaneous bleeding. And hopefully we've identified a number of good research priorities. When it came to von Willebrand disease, as everybody knows, the guidelines were recently published. We still felt that we need to really do a better longitudinal characterization of joint health. And that should include bone and joint changes, how that affects clinical function, pain symptoms, physical therapy assessment over time. And additionally, we wanted to capture the male journey. We wanted to look at anti-angiogenesis agents for certain types of bleeding events, and certainly wanted to improve diagnostic testing. We don't want to solely rely on specialized coagulation labs to be able to do these tests, because we need these in real time. Moving on to inherited platelet defects, we really felt like we really didn't know much about, qualitative platelet disorders. And we felt like, we really could benefit from a natural history study, really focusing on quality of life, how the relationship of medication affects these defects. And then all of us soundly said, we need to improve the standards of diagnosis. We had the same technology as many decades ago with light transmission aggregometry and whole blood impedance. And we really need to establish standards for diagnostic testing. It didn't get as high of a score because I think we were a little bit pessimistic that there was anything better out there right now. Moving on to disorders, EDS, HHT, and bleeding of unknown cause. We certainly had lots of questions about defining BUC, standardizing the workup, defining the risk of thrombosis, why does it happen? And then we really felt like they could potentially benefit from a collaborative effort and longitudinal evaluation. And I know there's some efforts going on right now within Athens, but certainly we thought there could be some benefit using our existing infrastructure. We felt like there hasn't been determined an appropriate hemostatic evaluation, particularly in children, and a national biorepository would be definitely welcomed, as well as a better way of diagnosing hypermobile EDS, which is a big struggle right now. Moving on to novel therapeutics in the last few, we really wanted to focus on development of new therapies, such as aptamer-based therapies. We wanted to see, is it feasible to give von Willebrand factor subcutaneously? Talking to our industry colleagues right now, the technology isn't there. We felt like we could potentially use other drugs, and we should study those in disorders like BUC and mild qualitative platelet disorders. And certainly, we wanted to look at differential responses to DDAVP and whether, if we do bring DDAVP back, could we come up with a better dosing regimen that's a bit more than just 2 different doses, particularly intranasal. The last few here are aging, and we will get to some of the questions. I see some hands raised. When it comes to aging, we really felt like we don't know a lot about this. And obviously our patients are living almost as long as the regular population. And certainly we want to study the effects of bone and joint health, and how, if there's an acceleration of changes over time. We want to look at the use of antiplatelet therapies. As our populations age, they develop cardiovascular disease. We want to look at the surgical risk of bleeding and as it changes over time, because we know when they're 5 years old and they have von Willebrand's, their bleeding risk is probably different than when they're 75 years old. And certainly we want to look at joint damage over time, how that affects activities of daily living. Our patient community definitely was interested in this, especially venous access. And certainly one of the things that really has to be done is what happens to levels over time, and what are the appropriate age norms. And I know there's some data coming out at upcoming meetings. So why should you be excited about our topic? Well, these are handpicked by a diverse group, as mentioned by Annetta, mentioned in her group as well. And we're really dedicated to and invested in the outcomes. Many of us do research in this, so we really feel very strongly about these priorities. There are a large number of key priorities in mucocutaneous bleeding biology. And so we feel like this is an opportune time. Hopefully some RFAs will come out after this, using some of the priorities that we outlined. And we are hoping that this will inspire collaborations to improve the diagnosis and management of BUC, HHT, and EDS. These are disorders certainly require a lot of our attention in the upcoming years. Again, I wanted to mention again our wonderful group that we have here. Certainly, Veronica and I could not do this alone. Certainly, I want to be thankful of our representative as well, Dr. Barbara Conkle. Everybody played a great role in this, particularly toward the end when we really had to buckle down and get this done. So we're really excited with the results that we have, and that's all we have to talk about right now. And certainly we'll defer to the end for questions. Thank you very much.
Thank you, Dr. Sidonio. That was very informative, and we really appreciate it, knowing you had some internet problems there. Dr. Baker, do you think that your screen is able to be shared now?
I think so. I'm hoping so.
Perfect. It is. We're seeing, you need to put it just in presentation mode. That's it.
Of course. Thank you. So I want to thank everybody again for their patience, and our wonderful co-chairs, Tyler Buckner and Vanessa Byams, as you see pictured here. We have no conflicts to report, and these findings and conclusions do not necessarily represent the official position of the Centers for Disease Control. This is to give you a quick reminder of where our work group stands in relation to the others. And while we were focusing primarily on 3 topics, we also had the questions related to the fields of public health, digital health, healthcare delivery networks, mental and behavioral health and pain, communication, and patient-reported outcome measures. And many of these topics are interwoven into other working groups that you've had the chance to learn about. So our task was to recommend 3 to 5 top priority research questions to NHF to consider actively promoting over the next 10 years in these 3 diverse areas. I want to give a nod to our incredible working group. We had over 20 committed, engaged patients, advocates, public and private partner leaders, academics, healthcare professionals, most but not all of them mentioned here and noted here in the pictures. They were tremendous. We had very limited time, 3 very big topics to tackle, which was overwhelming at the outset, honestly. And we thought to outline a method to bring structure and order to the process. While each of us on the working group have expertise in some specific areas, no one of us had specific expertise in all of the areas. So we thought that we would organize our time by each of the topics to get a foundational understanding of them, and doing that by bringing in subject matter experts. So the first week of the month of April, we had Dr. Mike Nichol from the University of Southern California in the School of Public Policy. And his research focuses not just on policy, but on state preference assessment, cost effectiveness. And he's also the PI of the Hematology Utilization Group Studies, known as HUGS. So we used a Jamboard, which is a type of whiteboard that many might be familiar with, and it allowed us to give real-time input, questions, comments, reflections, as well as time away from our weekly meetings to do some of our work. So the Jamboard proved incredibly valuable. We had themes of cost effectiveness, outcomes, pain, mental health, and from that, we drafted about 85 draft research questions and topics, which we scored. These are the main themes of those 85 questions. They're focused on 5 topics: marginalized and minoritized populations, health, behavioral health support and services, insurance coverage, the HTC specialized care model, and telehealth. And within each of those main topic areas, we focused on quality of care, satisfaction, costs, outcomes, including the development of PROs. And we had a number of questions, and I'll just give you a flavor of a few of them. So for example, in the marginalized and minoritized populations, one question that's still in a bit of a draft form would be, in transgendered patients with bleeding disorders who are undergoing gender-affirming surgery, does management in an HTC improve bleeding outcomes at the time of surgery? We tried to the best of our ability to fashion our questions in the PCOT format. We were successful sometimes, and we need some work on others. Here's another question from this area. Do services that aim to support mental health, well-being, quality of life, pain management, and healthy lifestyles, do they improve the patient experience, patient outcomes, or costs associated with bleeding disorders, diagnosis, and illness management? So they were, for example, we were looking at a research question that would specifically focus on mental health services above and beyond what is traditionally offered at hemophilia treatment centers. So that's just a taste of a couple of the questions on some of the 5 themes in health services research. We spent the month of April looking at health services research questions. In May, we started afresh with a new subject matter expert, and we were very fortunate to have, not just as a member of our group, but also serving as a subject matter expert, Dr. Melissa Creary from Dr. Creary has 2 positions. She is the Senior Director of the Office of Public Health Initiatives at Athens, and she is also at the University of Michigan School of Public Health as a professor. And her expertise is applying critical race theory to bleeding disorders research. That was our focus. We used the Jamboard questions format, and we're applying an anti-racist lens to our work. And some specific questions we were asking during this month were, how do racism, sexism, phobias operate in data collection, clinical care, community engagement, policies, and systems? What must be challenged? What structural forces contribute to inequities? And these were some very difficult discussions It really brought our group together. This was really foundational in all of our efforts to have structured opportunities to grapple with DEI in an organized fashion, in a psychologically safe fashion. And it really, I think, was transformative for the group. So among the questions that we generated and scored, which were numbered at 13, they bubbled up into 5 different themes, as you see here, starting from the top. We wanted to have, we were looking at questions that engage active partnerships with marginalized and minoritized populations in educational programs. Moving over to the right, we had a theme of understanding the lived experience of the marginalized and minoritized populations. We were also looking at barriers and facilitators to accessing research opportunities. A 4th theme was how do we best mitigate individual provider behaviors, clinical and organizational structures, and other systems that are in place that hinder equitable delivery of healthcare services. And then finally, we had a theme of identifying conscious and unconscious bias present within HTCs. So we have marginalized and minoritized populations have a number of characteristics, such as you see on the right in the box of race, ethnicity, sex, gender identity, sexuality, age, income, disability status, language, culture, faith, geographic distribution, and country of birth. So one example of a research question is, how do we best understand the lived experience of marginalized, minoritized populations? So do they experience care and services? How do they experience care and services within the HTC setting? And there we really recognize the need to conduct needs assessments to really articulate the problem from the positionality of these populations. Another research question that arose to the surface was equitable delivery of services. So for example, what programs or pilot projects could be implemented to lessen individual provider behaviors, to lessen clinical and organizational structures that hinder equitable delivery of healthcare services. That was what we focused on in May. June rolled around and we started afresh because we all needed a grounding in implementation science. And for there, we were very fortunate to have Dr. Brian Mittman, who's a research scientist with Kaiser Permanente Division of Health Services Research and Implementation Science. And he has a number of appointments with the VA, with UCLA and University of Southern California. And we used our Jamboard. We had an excellent lecture. And from there, we drafted 27 research questions and ideas that we scored. And some of our questions there were synthesized into 5 different themes, such as using existing resources and data to guide, to assess guideline concordant care. And that's really relevant given the new VWD guidelines and hemophilia guidelines. A second theme was identifying HTC characteristics that increase adoption of evidence-based behavioral health interventions. A third theme was assessing and promoting health equity and anti-racism within organizations and institutions. A fourth was enhancing cultural relevance of the interventions that we hope to propose and enhancing the relevance within specific populations. And the last theme was what HTC characteristics might lead to higher rates of adherence to prophylaxis. So among the many questions that we generated, let me just give you a few. So for example, in the behavioral health theme, one draft question was, in centers that care for individuals with inherited bleeding disorders, what characteristics increase the adoption of mental health and pain management evidence-based interventions for affected individuals? Another theme, another question from one other theme, for example, in prophylaxis, here's a question. In centers that care for individuals with severe hemophilia, what practices, programs, or center characteristics lead to higher rates of adherence to regular factor infusions or regular non-factor replacement? We had a number of reflections that our group left us with when we concluded some of our formal work in late July, and I just wanted to share some of those with you. But as we reflect on these, we wanted to share that not only do we feel necessary to provide to NHF draft research questions that are prioritized and scored, but we also thought it was very essential to promulgate some priorities. And the first priority that we put together was this. It stems from our conclusion that given the current relative lack of expertise in HSR, DEI, and IS within our community, particularly our community of researchers, that organizations like NHF and others should commit significant resources to recruit, to educate, and to train members of our community in these three areas, that we need to actively partner with experts in health services research, in DEI, and in implementation science outside of the bleeding disorders community. That was our first priority. And secondly, we will recommend, it really recognizes the extraordinary atmosphere of honesty and commitment and partnership that developed among our group members during our time together. We had a shared sense of purpose, particularly with respect to advancing diversity and equity inclusion in our initiatives. So as we move forward in creating the work products, we will articulate this priority, that systems are needed, that support and empower each person in their efforts to bring the amazing advancements of medicine to the entire bleeding disorder population. And with that, I hope it gives you a taste of what we have accomplished so far, and that it interests you even more in joining the State of the Science Summit. Thank you very much.
Thank you. Oh my gosh, it just sounds amazing what you did. So from NHF, thank you very much. We appreciate that.
Thank you very much.
Dr. Shavit.
Yes, hi. All right, let me go ahead and share my screen. All right, you guys see the slides?
Yes.
Okay. Oh, and I'm at the end. So I forgot I left that up there at the end. So hang on. Okay. All right. They're back up?
Yes, they are.
Yep.
All right, great. All right, so hi, I'm Jordan Shavit. I am a professor of pediatrics at the University of Michigan, and I was a part of Working Group 6. So Working Group 6 was actually considered to be a large task, and it was really more like 3 separate subgroups. This was in cooperation with Guy Young, who in our mission was to work out how to facilitate priority research. Guy Young was in charge of infrastructure, Maggie Ragney in charge of resources and funding, and I was in charge of workforce, which I'm going to talk to you about today. We actually essentially operated mostly on our own. We did occasionally meet together to talk about our progress, but most of the work was done in these subgroups. So this was my subgroup. It was a number of people across the country, different levels of experience, physicians, but not just physicians. We had a nurse practitioner. We had representatives of the patient community, industry, and from NHF as well. And so a big thank you to them. I couldn't have done it without them. So the first question that we talked about was, who is the workforce? We felt that this was important to discuss. And of course, there are the classical people that we think of the workforce, the primary caregivers, support staff. This is the HTC that we know and love. But more and more, we've been developing relationships with ancillary caregivers and other research staff that either cooperate with or function as a part of the HTC. So our targeted areas, and this was really designed by the parent committee, was to look at how we can develop the workforce of the future. What is the workforce going to look like? What is it going to need? And how are we going to maintain it? So, right, so the membership of the workforce, the skill set, recruitment, retention, mentorship, and then training, research, and funding. How novel and multidisciplinary approaches to training, multidisciplinary team science and team research, and funding models. So we did a lot of, we did some research in the literature, and then just a lot of brainstorming and discussions and coming up with ways to work on things. But first, we wanted to define the problem. Classically, everybody thinks about the problem that there's not enough of us to take care of the bleeding disorder community. And we all believe that to be true, but we need data, right? So these are the presumptions, but how are we going to get at this? And so we felt one of our top priorities first was to study the problem. And after that, we came up with a number of priorities, what we called tier 1, 2, and 3. Tier 1 were areas that are primarily low cost, but high impact and relatively easy in the short term. And I'm sorry, I flipped through that last slide pretty quickly. This is stuff that we're going to get into in September. So I'm just going to highlight these areas without getting into them in detail. But so here's, areas that we can implement in the short term: funding, workforce inclusivity, some lobbying areas. And then tier 2 priorities. These are primarily high cost and high impact, but will take a little bit longer. Not, super long term, but maybe in the, months to a couple of years. And this was developing partnerships or fostering partnerships, targeting areas of need, and developing funding applications specific to workforce needs. And then finally, tier 3 were areas that are primarily long-term and new high-cost, high-impact projects. So really, ideas about building the workforce of the future. And some of this had to do with new ideas of the HTCs, where there might be a hub and spoke model with central HTCs that have all of these new comprehensive skill sets that then help smaller HTCs that may not have the resources to do everything. And then working on mentees and mentors, right? So the mentees are important, but also encouraging the mentors and developing funding so that the mentors have time to train the next generation. And then new educational and promotional strategies, right? Ways of education, ways of networking and developing relationships within the societies that we know and love, and also outside of our standard societies. And then, of course, last but not least, is diversity, equity, inclusion. Make sure that the workforce reflects the population that we take care of, and can be committed to serving all of our communities, and especially underserved communities. So again, I want to thank the committee that helped me with this, and I look forward to our discussion.
All right, well, thank you so much. I appreciate it. And then if everybody wants to come back on their screen, we do have several questions here. Let me pull them up. I think the first one that came in right about the time that Dr. Vendrogalski was speaking was that you had said it was an interdisciplinary team. Who was involved? Were there just researchers and physicians? Were there patients, community members? Who was involved in your team?
Yeah, all of that. So we had, for instance, community members or patient moms like Sue Martin from the National Hemophilia Foundation. We had several basic scientists. I include myself because I do both. I'm a clinician, but also a basic scientist, to discuss aspects laboratory-wise, but also in terms of research opportunities on patients. Goes hand in hand, the hemophilia mouse and the hemophilia patient, in terms of the progression of hemophilic arthropathy. We had physical therapists on, like Bruno Steiner and Lena Volland, also from the National Hemophilia Foundation, in regards to physical therapy questions. We had advisors from the outside in terms of orthopedic surgeons who helped us, and pain specialists like Kalpana Gupta from Irvine. So it was truly a multidisciplinary. Whom did I forget? Chapter pharmaceutical industry. And I think that is also important because they provide us with the treatments for all of these diseases. And it's good to have them involved and have them feel our pulse and we feel their pulse. So does that answer the question?
Oh, I think it did. Thank you. One of the other things is it seemed like you covered so many things in your working group. As you think of moving forward, how would you plan to move these issues from this stage to that next stage? Because you had so many different groups working and so many people working on those groups.
Yes, that is actually, you will see that when you join us in September for the state of the art. So that came in through the scoring. So after we have, there's so many so many good topics. I'd say there were at least 30 to 50 topics in each of those working groups. And I think others here speaking today have that same experience in terms of the sheer number of important things coming up. And then after thinking out of the box with all those good ideas, we had to whittle it down. And this is where all these things came in, right? Like feasibility. Is it not feasible because we are complete lack of infrastructure, or not enough patients to answer a question in a large randomized trial, and on it goes. So then at the end, we were maybe ending up with 10 important questions per group, and those should all be answerable. And then the question is, how does one move it forward? And I think that will be then us and NHF's task to sort of find a way by either providing funding, industry perhaps providing funding, us now working collaboratively together after we have established all those collaborations, and simply stay on the ball and fly with it, rather than just talking like what we did over the last half year, so that it doesn't, fall into a sinkhole.
Yes.
Yeah, and I think it's also worth mentioning that this will all be in manuscript form. So it'll be reviewed. And I think we're hopeful that there'll be solicitations, requests for applications. We hope this will sort of simplify what, industry, patient advocacy, government organizations look at as what we need in our community, because we all got together and decided what we needed.
And definitely, I think we'll be looking at the working group 5, what Dr. Baker had addressed, implementation science, as to how do we implement some of these wonderful ideas. So
exactly, there are so many cross-cutting concerns, which is wonderful to see. But the next step is to provide sufficient operational resources so that we can get together in an organized and effective way to move these wonderful ideas to some fruition.
And that will take the whole community, obviously, to do. So the next question, I think, is for all of you. In generating the research questions and the focus areas, what were some of the challenges that were encountered in the respective working groups? And then how were those challenges mitigated? So looking at, as you got your research questions that you identified.
I think Judith outlined, very well how they worked through the challenge. And I can tell, I think all of us felt overwhelmed at the beginning. It was a lot to cover, limited amount of time, but you can see how we all sort of, used a general approach. Some of us used different things. The Jamboard was a great idea. We broke up into different smaller groups, and then got back together and reviewed the scores to make sure we all agreed. The key was that we had consensus. We had lots of meetings and lots of work outside of those meetings. Certainly, and I think it's important for people to understand, even if the scoring system didn't give it the score that we thought it would, a few of them, as you could see, moved up the list. And if we felt very strongly that something was a research priority and it didn't get scored high, we still had the power to veto that and move it up. And I think you saw that in a number of our presentations, that we were able to move it up.
Well, and there is another question, that were any of the priorities, did any of the groups prioritize their projects based on cost?
Yeah, I can answer that. I mean, we certainly did. As I grouped them in the tiers at the end. We tried to prioritize what we thought was going to be low cost or high cost. And then there's a short term and long term, high impact, low impact. It's hard to do at this stage, right, with 100% accuracy, because you don't know for sure, right, until you start making budgets and thinking about it in more depth. But we certainly tried to do that, thinking, this is our realistic ideas, and then here's our blue sky ideas.
There were questions solely based on, sorry, Annetta, but there's questions solely based on, was it going to be very expensive? And obviously things that were easy, simple, inexpensive, high priority, they moved to the top. And, things still that were expensive were moved up there, but certainly took a little bit of a hidden score if it was going to cost a lot of money. So yes, that's a great question.
Well, the score sort of took that all into consideration. For instance, just a low or high cost by itself wouldn't move it up or down, but other accompanying factors. For instance, if this was a high cost project with a high risk of reward and a non-feasibility in terms of, for instance, let's say multiple center trial, etc., then it goes lower and lower and lower in the score because all of these other things were scored as well. However, if it is a high cost but high reward, easy feasibility, important to the community, lots of engaged community partners who would also like to see this forward, all of a sudden this would come to the top priority, although the cost might be high. So I think it's all a little bit relative, and we cannot just based on one unfavorable risk category or scoring category believe it's going up or down. It's a composite.
And if I may add to that, one of the issues that we discussed was the need for qualitative research and for that to be funded adequately, or not just adequately, but optimally. Because some of the answers, for example, to the DEI themes and implementation science, you can only get at answers through qualitative research. So we thought that that needs to be recognized and appropriately funded. And secondly, hybrid design. That some of these research questions do not lend themselves to the PCOT controlled clinical trial format. So kudos to NHF for including health services research, DEI, and implementation science, because those offer new methodologies and really critical structures to answer key questions of equity so that our entire bleeding disorder community benefit from these advances in medicine and science. And then thirdly, I would say that we really recommend strong partnerships outside of the bleeding disorders community that will really help advance all of our research goals.
Yes, absolutely. We have a few more minutes. There was an interesting question here. When you were scoring and ranking the research questions, were there any surprises regarding what topics emerged on top? And this could go to anybody.
What was sort of surprising throughout the process that on some things, because we were always a group of 5 or 6 voting on these things, we really were like 180 degrees apart on some of the things. For instance, is something feasible or not? And then some would have said not at all, some in the middle, and some yes, easily feasible. And so it just shows you how little knowledge there is in terms of what infrastructure is available, how some people view, well, that's easily doable, others not. And then we have a good discussion around that. It widens everyone's horizon around that subject, and we come to a better conclusion at the end. You know, it's by reconciliation, we pick then a score, but everyone has learned. And that was a surprise to me, how disparate we were on some of the items. And then by just talking about it, all of a sudden, we all came together on the same page.
Yeah, we on our novel therapeutics section, those were probably the lowest scores that we got. I was a little surprised by that. Some of it, there wasn't a lot of, we didn't feel there was a lot of innovation going on, and there may be things that we don't not know that are going on, you know, within the industry, of course. But, you know, gene therapy barely cracked, you know, the top 10 in novel therapeutics. I think the idea felt that potentially there's some ethics issues, feasibility, large enough population to target. There were so many questions that made it get a very low score. So I was a little surprised it got such a low score, but it was almost unanimous in having a low score. So that surprised us a little. Obviously, somebody could have a breakthrough and you know, change all that, obviously. So
Anyone else?
We found challenges with the scoring system and I'm sure we're not the only ones, but particularly because some of our topic areas would require changes in the political sphere. You know, these do not lend themselves to a PCOT question format or a clinical trial. So while we appreciate the incredible thought put into creating the scoring mechanism. We were really, feasibility and impact were very far apart on many of these. And we think the issues are so important. We know NHF thinks the issues are so important that that's why will be, professionally and insistent on indicating priorities and recommendations in addition to the scoring that we have put together.
Which sounds perfect. I thought it was interesting, the comment earlier about the discussions that you had, and it sounds like all of you had within your groups. How could those types of discussions be held in other settings? It sounds like you all had a wonderful opportunity, but how could those be taken to an HTC setting, a regional meeting setting, or a national meeting setting, so that these types of discussions can be continued?
Well, I think it's really easy to do. I mean, we've seen it done before. We've had these kinds of discussions as part of the NHF clinical fellowship. Fellows, what we call, graduated fellows used to talk about this in these very similar kinds of settings many years ago. And what it took was bringing us together. That those examples were either separate meetings that were just, for us, and bringing in some mentors as well to help guide the process, or as a sort of a adjunct to a larger meeting like after ASH, for example. And so it's just facilitating and getting the right people together in a small enough group where you can talk about these things. But
it kind of
very productive. Yeah, sorry, go ahead, Robert.
Yeah, Jordan. It sort of reminds me, like, we do our post meeting after we see all the patients, we have all the providers that see the patients, and we discuss all, any issues. Everybody goes around and makes their comments. Sort of reminds me of that, and how we try to at least make sure that everybody gets to have their comments about something that maybe we missed and maybe need to pay attention to. So I think that's, obviously, I think we're used to that model of having this. Certainly, some of us have patient committees in which patients have a say-so in reviewing what happens at our HTC. So I feel like after this, it makes sense to revisit that idea, to make sure there aren't blind spots, things that, that Judith's group uncovered. And obviously, everyone has blind spots, and I think it's definitely worth considering.
Yes, and if I may mention, my co-chair Tyler Buckner says it very nicely, that outside experts and facilitators would help, particularly for our areas, at least in the beginning. I would also say that we're extraordinarily fortunate in hemophilia that we have been organized as regions, geographic regions, with the intention and the obligation to build capacity outside of our own clinical walls to our regional counterparts throughout our states and neighboring territories. Many rare disorders like sickle cell, for example, has just been recently regionalized, but it's nowhere near our sophistication level. So structured opportunities, being intentional, providing optimal resources. We've seen this done in HRSA by prioritizing quality improvement, skill building throughout the Hemophilia Center network, or years ago when we had to respond to the HIV crisis. We did that intentionally, resourced thoughtfully through a regional structure, sharing our expertise, capacity building. We do this well, and now we're adding these new areas to our work.
I'm sorry, I was talking and I was on mute. Thank you all. I know that we still have a couple of questions, and we're at the top of the hour. What I would like to say is I hope that people will register and join us for the State of the Science Summit, which is held from September 12th to September 15th. And we will have similar discussions. It's set up so that we have a plenary, we have a summary of your work that you have done, as well as panel discussions where there will be 90 minutes of this type of discussion where you'll do a much more in-depth presentation and discussion of what each of your working groups have done, and then the opportunity for people to submit questions, comments, and have the response to that. So I hope people will join us on those days and help us move the work that you have done forward, because once we finish that summit, there will be more to do, and we will need the community to come behind us as we do that. So at this point, I'd like to thank our presenters for taking the time to join us this afternoon. We absolutely appreciate your time and expertise, not only today, but in the past 6 months to a year that many of you have been working with us on this initiative. So I would like to thank you all for joining us, as well as for our audience. Please note that this recorded webinar will be available on Friday, August 13th at hemophilia.org under the Events tab, with all of our archived webinars. And also available in the Events tab is our upcoming schedule for the weekly Wednesday webinar series. So with that, I'd like to thank you for joining us this afternoon, and have a wonderful week. Thank you all.
Thank you.
Thank you.